Now let's study atelectasis. Here there will be loss of lung volume due to alveolar collapse, and we have obstructive, compressive, contraction and adhesive atelectasis. As we can see in this figure, this is the compressed alveoli with no air spaces between the alveoli, and this is the normal alveoli with air spaces for gas exchange. Atelectasis. In obstructive atelectasis, the obstruction can be due to foreign body, mucus plug or the tumor. If this is the alveoli and this is the surrounding blood vessel or the capillary, due to any obstruction in this alveoli, there will be reabsorption of this alveoli and the air cannot be reached, or the new air cannot be reached due to this obstruction. Hence, the old air which was present in this alveoli will be reabsorbed by the surrounding capillary, and this capillary undergoes collapsing. Hence, in obstructive atelectasis, due to obstruction, this prevents the new air from reaching the distal airways, and the old air will be reabsorbed. And this is the figure. In this figure, we can see the obstruction. Due to this obstruction, this part of the lung, that is lower lobe lung surface, has been collapsed, and you can see the collapsed lung. We can see the collapsed lung. As we can see in this figure, this is the obstructive atelectasis. Here we can see the obstruction which causes the airway obstruction, prevents the new air from reaching, and the old air has been resolved by the surrounding circulation. And as we can see, this is the compressed lung and this is the pleura, and we have the mucus plug that causes the obstruction. Next type of atelectasis is compressive atelectasis. Here, due to compression, this compression can be any space occupying lesions or the pleural effusion. If there is any pleural effusion, that can also obstruct the airways, and due to this compression, external compression, that reduces the lung volumes. As we can see here, this can be pleural effusion or the tumor. This is compressing the normal lung, and this causes compressive atelectasis. Next, we have contraction atelectasis. This is also called cicatrization atelectasis. Here, there will be scarring of the lung parenchyma that distorts the alveoli. We can see this type of atelectasis in restrictive lung diseases, where there will be interstitial fibrosis like sarcoidosis. Due to this fibrosis, the alveoli will be lung parenchyma that distorts the alveoli. There will be distortion of the alveoli, and this causes contraction atelectasis. Here we can see the scarring. This scarring is due to fibrosis of the interstitium. Next, we have adhesive atelectasis. The main cause for adhesive atelectasis is lack of surfactant, and this can be seen in NRDS, that is neonatal respiratory distress syndrome, in premature babies. Here, due to collapsing of the airways due to increased surface tension, there will be adhesive atelectasis. Let's revise this. Obstructive atelectasis is due to obstruction, and compressive atelectasis is due to tumor or pleural effusion that is compressed in the normal lung, and contraction atelectasis is due to scarring and fibrosis. Adhesive atelectasis is due to decreased surface tension. And the complications of our clinical presentation is almost all the patients will be asymptomatic, but some patients who can be clinically diagnosed can have decreased breath sounds and dullness to percussion and decreased tactile firmness. The major difference between pneumothorax and atelectasis is the mediastinal shift will be towards the side of the lesion. In pneumothorax, the mediastinal shift will be away from the lesion, and in atelectasis there will be normal values. The PaCO2 or PaO2 will be normal due to compensatory mechanism. If the large area is involved, we can find the decrease in PaO2 and increase in PaCO2.